Very much, you two. Introduce yourself, where
Okay.
you work, and what is your specialty?
Introduce myself. Okay. So I can start from the beginning or continue.
Yes, yes. Just say who you are and
Okay.
where you work, and then continue. Yes.
Okay. Hello, everybody. I'm Wang Gui-qiang from the Department of Infectious Disease, Peking University First Hospital, and I am focused on the infectious disease control and diagnostic treatment. And in this COVID-19 pandemic, I'll deal with the treat and save the patients and generate the Chinese protocol for diagnosis and treatment. And I make many lectures in China to teach the physicians in the to treat the diagnosis and treat the COVID-19. So I continue my presentation here. From the autopsy and the biopsy, we can find many injuries from the by the lung. Here I show the the highlight for the left. From the left one, you can see the exudative inflammation, fibrosis, and focal hemorrhage. And from the right one, you can see the hyaline membrane formation. This is a very important figures from the patients, dead patients. You can see the this membrane, the impact on the oxygen exchange. And also we can see the velar exudation and the vascular hyaline thrombi. This thrombi is very popular in critical patients. So we have to treat them by the anti-coagulation agents. And also we can see the pulmonary fibrosis. This shows some the immunohistochemistry staining of lungs tissue. This you can see some the macrophage, T lymphocyte, CD4, CD8, and the B lymphocyte infiltration in the lung. That gave us a clue that this the cytokine storm happened in the lung. Many immuno cells infiltration in the lung, and also we found that there are cytoplasmic variants, many virus in the lung on electronic microscopy. This gave us clue that the long-term antiviral treatment is maybe necessary. There's another important finding from the autopsy and the liver biopsy. The immune system was injured seriously in COVID-19 patients. The spleen and lymph nodes biopsy and the autopsy, you can see the strength of lymphocytopenia and CD4, CD8 T cells reduced in spleen and lymph nodes, and also in bone marrow, many immunofunctional cells is decreased. Here she the other organs damaged by the COVID-19 infection, including the lymphocyte, spleens, and epithelial cells, renal, in the renal, and the hyaline thrombi in glomerular capillary, and the hepatocyte, you can see the degeneration and some necrosis and hemorrhage. There are different clinical manifestations, including fever, dry cough, and fatigue. Be awareness that in some severe or critical case, the dyspnea can happen rapidly in short time. So we have to monitor the patient very seriously to find the
Dr.
disease.
Wang, are you changing the slides? We see only the first slide.
Only the first?
Yeah.
Oh, sorry. Okay. It's changed? The slide changing? Hello? Can you see the change?
Yeah.
Yes. Can you hear? How about now? Clinical manifestations. Can you see these slides?
Yes.
Yes, we do.
Okay. So for the critical case, most of the cases happened in the elderly and those with chronic underlying disease. For the pregnant women and their children, the symptoms is similar with the others. And for children, the symptoms and the disease is relatively mild. Most patients mild and moderate. This slide show the sex and age. It seems for male and female is similar profile, but you can see most patients infected by coronavirus is more than 20 years old. In the children, it's less prevalence. And this is symptoms of COVID-19 in China. You can see the fever, dry cough, fatigue is very popular, and we can see other symptoms including headache, muscle ache, sore throat, etc. This slide shows the underlying medical conditions in COVID-19. In the hypertension, in severe and if very critical case, more patients have a comorbidity of the hypertension and diabetes, cardiovascular disease, and lung disease. For the laboratory test, we including the nucleic acid, viral isolation, and serological test. This slide shows with the disease progression, the antibody can be detected. This is blue, and the blue one, you can see the IgM, IgG antibody can be detected from the about 3 days of the onset disease. And the RNA levels decrease with the disease progression. There's an overlap between them. With the antibody increasing, detectable, the RNA levels decrease. We check this IgG antibody. It's about with the titer of IgG antibody, about 50% show the neutralization antibody. Chest imaging is another important part for the diagnosis of COVID-19. And you can see in the early stage, there are multiple spotted shadow and the ground glass shadows in the lung. And with this progression, the glass shadow is increasing. Diagnosis criteria is including epidemiological history and clinical features. If the patients have the epidemiological history and the tool for the clinical features, or all 3 clinical features, we can diagnose it as suspected cases. If the suspect cases in accordance with one of the following virological or serological evidence, we diagnose it as a confirmed case. One is a real-time RT-PCR show the positive RNA, or viral gene sequencing is evidence of coronavirus, or recently we add on the serological test. If viral specific IgM, IgG is positive, together, we can diagnose its confirmed case. Or where a specific IgG, the titer increase from the negative to positive, or 4 times higher compared with the onset of the disease. So serological test is important supplementary for the RNA test in the diagnosis of COVID-19. There are different clinical types, including mild, moderate, severe, and critical. So we have the different definition for this clinical type to give us the clue how to treat the patients. These slides show the distribution proportion of severe cases in COVID-19 in China. You can see the yellow one is a severe case, and the red one is a critical case. With the disease, with the aging increasing, the percentage, the proportion of the severe and critical increasing. So it's give us we have to awareness that we have deal with the aged people very seriously, because most severe and critical case is aging people. The proportion of deaths in different age group is similar with the severe and the critical case. More patients have the mortality rate. You can see with the disease, age increasing, the mortality rate is increasing. In the more than 80 years people, you can see the mortality rate is more than 20%. We have to treat all the patients very early stage. Early diagnosis, early report, early treatment is important for reduce the mortality rate. Supportive treatment is important because we have no confirmed antiviral agents. So supportive treatment is important. Early treatment, early supportive treatment. And another important part is early oxygen therapy and airway cleaning. Airway cleaning is another important issue for critical and severe case. This is we have the experience after the autopsy result coming, because there are many mucus plaque in bronchi. So this gave us gave the clinical treatment difficult. So we try to use many methods to get airway clean, including high frequency chest wall oscillation. It's kind of small equipment that get the just like the popping the back to get the mucus goes up. We can get the airway clean. And the antiviral therapy, we have a recommendation to treat COVID-19. We just recommend some agents that already on market with the good safety profile to try to use in COVID-19, including alpha interferon, collateral, ribavirin, albendazole, and chloroquine phosphate. And so far, with the evidence coming, chloroquine or phosphate gave us a promising information that is worked in COVID-19 patients. This study show the multi-center single-blind randomized control study to use chloroquine in COVID-19. You can see chloroquine phosphate and placebo control. You can see the disease exhibition is different, significant difference between these two groups. And also we find that this, the fever, duration of fever is different between these two groups. With chloroquine phosphate treatment, is the fever period is shorter compared with the placebo control. And also, glucocorticoid intervention is different with these two groups. With a severe and critical case, we try to use glucocorticoid treatment. But with chloroquine phosphate treatment, we don't need to use steroid in COVID-19. And also, we find that the improvement of chest CT scan, you can see the difference between that. So in summary, that chloroquine phosphate can be used in COVID-19, and also the safety profile is good. We have to monitor the heart and the renal side effect in the old people population. We generate some early warning indicators to predict the disease progression and to give the guide the clinical practice. For example, the peripheral blood lymphocyte decrease or elevation of inflammatory factors such as interleukin-6, CRP, and the lactate sustained elevation or long lesion developed, serum ferritin elevation, and the cardiac troponin increasing. These are some our work in showing that the survivor and non-survivor, you can see the big difference between the D-dimer. D-dimer is increasing in non-survivor patients, and also we can see the lymphocyte count is decreased in dead people. And a similar profile, you can see the interleukin-6 increase dramatically in the dead people, and also you can see the serum ferritin is high level in non-survivors. Here show the troponin increasing in non-survivor patients, and lactate increased, sustained in the high levels in non-survivors. So all these indicators can guide our clinical practice to treat patients very seriously in the early stage. We have other protocols for severe and critical cases, including respiratory support, circulatory support, and to support the organ function. And also we try to use convalescent plasma treatment, blood purification, and immunotherapy, interleukin-6 receptor agonist, tocilizumab, and other therapeutic. For the respiratory support, oxygen therapy is very important. From the nasal canals or mask, or high flow nasal catheter oxygenation, the invasive mechanical ventilation, and some rescue therapy for even ECMO. So I have emphasized the prone position ventilation is very important in the severe case, and including the air tract clean is very important. Prone position ventilation can give the chance to air tract clean. So ECMO in the late stage is not effective. So we have to use ECMO as early as possible. Convalescent plasma treatment worked. We have treated the COVID-19 in Wuhan, Hubei, and other cities over 600 all over China. Gave us a very promising efficacy effect data. So indications for convalescent plasma, including patient with rapid disease progression, severe critical illness. So we use 200 to 500 milligram convalescent plasma for each COVID-19 patients. We try to use tocilizumab on cytokine storm. So from the pilot study, it showed the promising efficacy data. So we are still working on it. Recently, we have just we start to launch a clinical trial, international clinical trial in Italy and Germany recently. Tocilizumab in the treatment is there's a serological evidence, because in COVID-19, in severe and critical case, the elevation IL-6 is very common. So IL-6 elevation can cause cytokine storm, can trigger the cytokine storm. So we just try to inhibit this pathway. Blood purification is another important treatment method to get to release the cytokine storm. We can use plasma exchange, absorption, purification, or the plasma infiltration, filtration. So we try some case, severe and critical case, is to find a good result. And traditional Chinese medicine, we tried many different strategies to treat COVID-19 patients, including some compounds, some granules, and some capsules. So we still analyze this efficacy result. Okay, I would like to, okay, there's a criteria for the isolation discharge. There's we have restrict criteria for the isolation and discharge. We have the patients have 2 consecutive negative nucleic acid tests. We can discharge the isolation, the patients from the hospital. After the discharge of the hospital, we have to monitor the patients at home for another 14 days. The patient have to wearing the mask, leave the well ventilation single room, or reduce close contact with family member, and separate dining, etc. Because we do find some redetectable of RNA after discharge from hospital. So this part patient may have the infectious. So we have to monitor the patients and isolate patient at home for 14 days. And we recommend patient to go back hospital 2 or 4 weeks after discharge from hospital, because we find some these pulmonary fibrosis and the pulmonary function dysfunction. So we have monitored all the patients after discharge from the hospital. Okay, I would like to close my presentation. Thank you for attention.
Thank you very much, Dr. Gui-qiang. I'm sure we will have many people very much interested, especially in the medical sector here in Sweden and Europe and maybe in the United States, in your findings, but also in your recommendations. I hope you can stay with us until after the second panel to take questions, because we have to go directly to the second panel. And then after that, we can have questions to you and the other panels, because we have shorter time. I can also announce that we extend the webinar to 12:30, not to 12 as earlier, so we can give people enough time. Thank you very much, Dr. Wang.
Okay.
Now we go directly to the second panel. This panel is dedicated to discuss the economic role of the Belt and Road in building a healthcare frontline globally. It's no secret that this pandemic, the first question was to Dr. Wang Gui-qiang from Beijing. A question from Mr. Richard C. here in Stockholm. His question was, I don't know if you can answer that, is what is China doing to prevent a second wave of outbreak of corona after they controlled the first wave?
Yes. Okay.
Yeah.
Can you hear me?
Yes, we hear you. You lower just the camera so we can see you better.
Okay.
Please be brief.
Okay. Okay, this question is how to prevent the second wave for China, right? So now in China, we have the strategy to prevent the import case and prevent the second wave in China. So the first thing we have to do to control the import case. So we detect all the import passengers in our border to make sure they have not infected. Even some of asymptomatic cases we happened from the Russia, China border and other, and the Guangzhou, the city. So this is the first thing we can do to detect all the passengers coming China. And the second, we just to control the second spreading from the imported case. This is the second part we have to do. The third part, we have to prevent the cluster case in a hospital, in the school, or in some office. So although we start to recover the working and the schooling, but we still keep the high levels, the prevention strategy. We pursue the people to have the mask, face mask in the crowded and the narrow room, so to prevent the possible infectious patients. So although we did a lot of things, but we still have the risk to get the new case in domestic China. So far it's good. We are still working on it.
Very good. There was another question, just briefly, if you can answer that, on the question of immunity after recovering from the COVID-19.
Yeah. Okay.
What are your observations on that?
Yes, we do find that neutralize antibody in the recovered COVID-19 patients. So it seems that the recovery patients, COVID-19 patients, they didn't have a reinfected. It's not possible to get reinfected because the neutralized antibodies work there. We didn't find a reinfection so far. Although there are some redetectable RNA after discharging from the hospital, and for some rare case, they are sustained RNA positive. So for this part patients, we did a pilot study for that patients for redetectable RNA or sustained RNA positive patients. We found that in this part patients, it seems that the immune response is weak, including the memory T cells and the active T cells. The levels is lower compared with the recovery patients. So for some patients, maybe have the long-term viral shedding, but most COVID-19 patients recovered well. Is still working. Is a better outcome. Yes. Thank you
very much, Doctor. I really appreciate your contribution. I know it's getting late there in China, but I'm happy you are still with us. Please stay with us.
Okay.
Thank you. The next